Welcome to the continuation of the series on advocacy and public policy, primers for the public as well as healthcare professionals. This program was created by myself, Jay Mirtallo, Clinical Practice Specialist, and Peggy Gunter, Senior Director of Clinical Practice Quality and Advocacy for the American Society for Parental and Enteral Nutrition. We hope you enjoyed the overview that was provided in part one, or if you haven't referred to that yet, we recommend that you go back and help establish that foundation to see all the different aspects of what we try to do in advocacy through the ASPEN organization. This section is part two, Agenda and Strategic Priorities. The objectives of this session are to, one, review ASPEN's past activities in advocacy and nutrition support. In the next part, discuss the current ASPEN public policy agenda and strategic priorities. And then third, describe some of the ASPEN activities related to the executive branch that we've been involved with. So let's talk first about advocacy and nutrition support and ASPEN's role in that ever since the organization was created. Basically, ASPEN advocates for research funding, adequate reimbursement for nutrition support, and assurance of a continued role of nutrition during healthcare reform. In research, we advocate for the research that's going to help advance clinical practice. And we also know that for basic science research and researchers in the field, the National Institutes of Health is the largest single supporter of nutrition research, and we were involved early on with other organizations to help support and get funding for clinical nutrition research units, which have been in existence for a number of years until recently. For reimbursements, we've been looking at payment of nutrition therapy in all healthcare environments. We've had problems in getting agencies and or organizations to distinguish enteral and parental nutrition from food and other basic nutrition. We've advocated for reimbursement for professional services, determining what we think is reasonable to be paid for, and then if it's being paid for, who are individuals that are competent to perform that service. And in this area, we've linked with other committees within ASPEN. In this particular area, we've been working closely with clinical practice for a number of years. I'll give you an example of one reimbursement area that was highly important to us early on, and that's the Medical Nutrition Therapy Act of 1999. This act authorized the appropriation of funds for dietitians to provide medical nutrition therapy services to those with diabetes and renal failure. But along with this, there's specific criteria for assuring the competence of those that provide that service, and also a gatekeeper kind of function, which is here in this case, a physician referral. And we'll refer back to this as we talk about our continued efforts on the evolution and revision of these acts to make it more appropriate and access to more patients. In the regulation area, we've worked primarily with the Food and Drug Administration, especially with the relationship to drug products, intravenous nutrients, and parental nutrition. We'll provide some examples of that later on when we talk about the examples in the executive branch that we've been working on. In safety issues with parental nutrition, we started in my first recollection with the FDA safety alert in 1994 concerning intravenous lipid emulsions, acting as an expert to help provide issues, help resolve issues with regards to safety in compounding parental nutrition products. The other area we've worked with in the past is medical foods, the classification and labeling. We're still working on that and trying to get the foods, especially being recognized as not just food, but therapies that are important to our patients. Some of the other nutrition support activities we've been involved with in the past is we serve as a resource to Medicare and its carriers concerning clinical practice. We've provided clinical advice to the FDA on medical foods, intravenous catheter complications, drug shortages. We continually monitor activity in Congress as it pertains to home health care, technology assessment, and professional involvement in nutrition support. And we continue to advocate for nutrition to be included in federal government reports and assessments concerning health and disease. So with that historical perspective, let's now turn to our current involvement with advocacy and public policy. And we can talk about our public policy agenda and our initiatives. You can find these on the ASPEN website under the Public Policy tab. But just to serve as a foundation for you. ASPEN has an advocacy goal. We serve as a responsible voice for nutrition support to inform and influence policymakers, payers, healthcare organizations, as well as accrediting bodies. In our agenda, our mission is to seek an environment in which every patient receives safe, efficacious, and high-quality care by advancing the science and practice of clinical nutrition and metabolism. We have specific objectives in summary, and it's an active advocacy for high priority issues pertaining to nutrition support. So we spend a lot of time in the Public Policy Committee helping make decisions about what we are going to prioritize our time in regards to activities on a continual basis. Since we're a small organization, we also work with other like-minded organizations to help get support for the impact that we want to make on specific issues. We work through the Congress, we work through the executive branch, and public-private groups, as well as the courts. Here's just an example of the public policy objectives that we advocate for. It helps serve as a roadmap for us to work as a public policy committee and as an organization, help us connect and engage with the ASPEN Board of Directors, but more importantly, our patients as well as our membership. To make sure we're advocating for things that improve their practice, improve access to therapies that are providing, and help improve the quality of what's being provided from parenteral and enteral nutrition. So one of the first things we do is advocate for optimum nutrition. We've been working with trying to establish a patient safety goal with the Joint Commission for a number of years now. We've always worked with patient access to nutrition through changing reimbursement. And even though we think we solve it, the reimbursement changes with new bills and other areas coming in that we continue to have to monitor to see if that's going to impact in a negative way any of our patients or our providers that are providing care to patients. We advocate for needed products and product shortage solutions, improve safety and quality care for all patient consumers. We want to make sure we have a fair market price, especially related to pricing, which is something we've been working on, especially in the last couple of years. Funding for research and promoting an interdisciplinary approach to public policy, as well as funding for nutrition clinical services. When we look at ASPEN public policy, there's some initiatives we try and follow. Regulations is key. One's been related to information technology and safe practice issues related to parenteral and enteral nutrition. Working on the definitions of medical foods and billing codes for malnutrition, nutrition therapy, and metabolic support. Making sure our new definitions for disease-related malnutrition get incorporated into the regulations appropriate for coverage for reimbursement. And then always looking for adequate coverage and reimbursement for PEN. Funding for support for healthcare professional education and training has been something on our radar for the last 2 years. And supporting nutrition support related research has been going on for decades. Here's a list of some of the legislative priorities that we advocate for and keep a focus on. We're always interested in advocating for Malnutrition Awareness Week, getting congressmen and senators to support the resolution that's presented early on in the fall for each year. We also have been working with medical directors for CMS on the local coverage determinations for home parenteral nutrition. Currently looking at the issue of pricing for unapproved peanut products achieving FDA approval. That's a safety issue as well as an access issue to our patients. Parenteral nutrition drug shortages has been something we've been working on for not only just the last decade, which has been constantly in our mind, but previous decades before when products go out of off the market or products have problems with making them access. And then we support for nutrition and medical education. And the most recent regulation that's come through is the proposition for a National Institution of Nutrition Act. And the latest one that's going on is the update to the medical nutrition therapy bill, which we'll talk about in a couple of slides. In order to advocate and work with these priorities, we work with other organizations or coalitions. One we've worked with the longest now has been Digestive Disease National Coalition, or what we call DDNC, or they call DDNC. It's a public policy forum that we attend on an annual basis in the spring, where we make a visit to the Hill. We take our legislative priorities and discuss that with all the other members that are going there. So when we meet with congressmen and senators, we can propose to them what we believe are the important issues related to GI and nutrition currently going on, and advocate for both legislation that's in the House right now or upcoming legislation, as well as in some areas, since the Congress does oversee agencies to make sure that they're providing quality or whatever, if there's any access issues related to reimbursement or coverage, we bring those up as well. Next area is the Defeat Malnutrition Today. This organization is focused on malnutrition, especially in the elderly. They help develop and get the resolution for Malnutrition Awareness Week to submit to Congress so it can be supported or endorsed by different representatives. More importantly, is they developed this blueprint to assist with national and state malnutrition advocacy efforts. I'm from the state of Ohio. We've used this in Ohio to help get a bill passed to create the Malnutrition Commission that created a report on malnutrition in the elderly and made recommendations for what needs to be done in order to improve that. The Healthcare and Nutrition Council covers nutrition issues of interest to ASPEN. Worked with them with drug shortages, coverages for ENPN, medical foods, as well as malnutrition for all groups, not just elderly. And the Nutrition Action Alliance is supported by the American Society of Nutrition, and this supports and lobbies for approval of the National Institute for Nutrition. From ASN, there's a white paper that was prepared by Tufts and published in the American Journal of Clinical Nutrition just in the spring and summer of 2020 that highlights why a National Institute of Nutrition is needed to coordinate nutrition research and advances that need to come in the field. So let's list a couple of the congressional bills that we've supported. The Medical Nutrition Therapy Bill, which is currently of active interest for us here in the fall of 2020. That is HR 6971, the Medical Nutrition Therapy Act of 2020. That was introduced in May of 2020. And the important thing here is taking from the bill that was passed in 1999 is the expansion of MNT services to other diseases, not just diabetes and kidney disease, such as malnutrition, obesity, cancer, and eating disorders. It also allows for referrals to be made by those other than physicians, which would be a physician assistant, nurse practitioner, clinical nurse specialist, and a psychiatrist in regards to eating disorders. And in August of 2020, S4504 was submitted to the Senate. And this is a bill to amend the Title 18 of the Social Security Act to expand the availability of medical nutrition therapy services under the Medicare program. Other bills we've advocated for during the 2019-2020 session is one, the Medical Nutrition Equity Act of 2019, the expansion of nutrition's role in the curriculum and healthcare, which is titled Enrich, providing grants to help develop and enhance integrated nutrition and physical activity curriculum in medical schools. The drug shortage legislation, Meds Act, which was introduced in the spring of 2020, and then the National Centers of Excellence in Continuous Pharmaceutical Manufacturing Act. And you'll notice with some of these acts, you may see individual ones, but when certain things come along with different opportunities, some of these acts may actually be incorporated into other acts that are bigger in nature and carried along with them, because it might be, in some cases, easier to get them passed than getting passed on alone. Example here is that these acts, I think, have been addressed or may have been addressed in the CARES Act of 2020. And the Older Americans Act is continually revised and improved. And the one that was submitted in 2019 is to reauthorize it, as well as revise several programs administered by HHS and the Department of Labor relating to care for the elderly. And among other things, the bill reauthorizes programs that support nutritional services such as meal delivery. So that is ASPEN's public policy agenda, as well as legislative priorities, and giving you some examples of things that are actively worked on a continual basis. Let's talk now about some of the activities ASPEN's been involved with the executive branch. First, Dr. Gunter, or Peggy Gunter, has been involved, continually working with the Agency for Healthcare Research and Quality, looking at statistics of inpatient stays as it relates to malnutrition, parenteral nutrition, and enteral nutrition. Some of the data is shown here on this slide, where we see the number of hospital stays that's been identified over time, and finding that the malnutrition itself has found a large increase in the number of patients that are diagnosed with malnutrition during their hospital stay. And then the enteral nutrition and parenteral nutrition graphs on the bottom show a continual use of these products in our patient population, with not much change from there. With the FDA, drug shortages has been a continual problem that we've worked on over the last decade. ASPEN's provided multiple opportunities for guidance and conference calls. We've participated in conferences and looking how the overall drug shortages and supply chain issues can be addressed in a global sense that would make the supply chain safer or more reliable for our products. We've had meetings with FDA as well as we've advocated for legislation to support the FDA. One other area that we're continually working on a routine basis related to actually access of parenteral nutrition products for our patients, not just related to drug shortages, but other areas as well, is looking at the FDA's approach to new drug applications and bringing in new products for us. We've had conferences related to that, FDA visits, publications, and letters. In this slide, we provide the example of our work with the FDA developing a workshop to help establish an appropriate clinical trial design for intravenous fat emulsions, so that the FDA's approval process could be accomplished. In this case, we're looking towards how do we get more products into the United States that might be more applicable to our patient population, and how do we accomplish that through the FDA, whose primary mission is to promote the public health and safety for our population. In this particular case, once that was in place and we've had those discussions, we now have 3 additional lipid products on the market in the United States that we did not have prior to that. And that's accomplishing one of our major goals. We also work and continually have a conversation with the Center for Medicare Services, working in the topic areas of malnutrition audits and education task force, continually trying to look at malnutrition quality measures for those individuals, and more acutely is looking for I would say a modernization of the local coverage determinants for home parenteral nutrition. And we're trying to move away from albumin as the primary definition of malnutrition to our more current determinants of malnutrition that we've been incorporating based on disease-related malnutrition criteria. In summary, we go back to our slide we covered from the overviews. How does ASPEN do this? We have a public policy committee that coordinates that. And we have other committees in the organization. The malnutrition committee works with a lot of those malnutrition task force, but in conjunction with the public policy committee. We have a website that we keep track of, and you can find what our up-to-date public policy agenda as well as legislative priorities are. And just know that the staff and committee members always follow the issues and work on legislation as well as partner with coalitions. And then we try to attempt to communicate this through various venues on our website, Clinical Practice Highlights. We try and send emails out to our membership as well as patients if they're important stakeholders. That's call to actions. And we try and incorporate the stakeholders that have a key interest in the work that we're doing in improving the access as well as availability of quality, safe enteral and parenteral nutrition for our patients. We hope you are enjoying this primer and would like to see that you would follow through the third primer, which will be coming out shortly, and that's looking at tools for you to actually get involved and continually improve your work in advocacy for enteral and parenteral nutrition.